All right. Hey, Nijmegen, hoe is het in Nijmegen, Willem? Alles zijn gangetje?
Prima, heel goed.
Heb je tekort aan neonatologen in Nederland of niet?
Nee, wel aan een verpleegkundige. Dus dat is in heel
oké.
Nederland een heel groot probleem.
Ja.
Waardoor toch ook in alle centra wel je gedwongen bent om bedden te sluiten. Ja, dat is echt heel naar. Ja.
Ja. Ja, je hebt de actie, je hebt de spullen, je kan alles doen, maar...
Ja. Nee, maar ons team is verjongd en dat is heel goed. En dat is fijn.
Ja.
We hebben echt,
Ja.
echt een topteam. Echt een goede samenwerking. Ja.
Ah, leuk man.
Ja.
All right, it is 2 minutes past. I think we'll just start and people will keep dropping in. I will share my introduction screen. It's a real pleasure to introduce Willem. Willem de Boode. He's a professor from the University of Nijmegen in the Netherlands. And Willem and I are trained, I think, in the same sort of years. As doctor and as pediatricians and as neonatal fellows. And we've both always been interested in hemodynamics. Willem did a lot of animal studies looking at hemodynamic monitoring and different ways of doing hemodynamic monitoring, but of course ultrasounds played a role there as well. He's the president of the ESPR, and he chaired special interest group with a neonatology performed echocardiography. And as I said, he's a very keen researcher and recently published his Benedictus trial, the big sort of PDA trial. He's going to talk to us about this trial, and he put the subtitle there, More Questions Than Answers. So at the end, we will have lots of time for some discussion. So Willem, I'm going to stop sharing and over to you to share.
Thank you very much, Kurt, for this very nice introduction. And well, thank you all for your interest in this presentation about the Benedictus trial. It's about management of the patent duct in extremely preterm infants and what are the lessons we learned from the Benedictus trial. And indeed, I think after 60 years of debate, we don't have the clear answer, but I think we're moving in the right direction, and I will try to show you what I think should be the direction. As I understand, you can ask questions via the Q&A, and there will be plenty of time to discuss after the presentation. First, I would like to disclose no relevant financial relationship, and the funding was by the Dutch and the Belgian governmental institution. Well, as already said, there's a lot of controversy about the optimal management of a PDA in the preterm infants, and especially when you're those that are born below 28 weeks of gestational age and or a birth weight less than 1,000 grams. That's because lack of evidence for or against different approaches. Already more than 6 decades, there are publications and discussions about what to do. And well, we started with active closure. We learned that the duct stays open thanks to prostaglandins. So if you want to get rid of a patent duct in preterm infants, it seems logic to, well, inhibit the prostaglandins. And they found out that you can do that with the cyclooxygenase inhibitors like ibuprofen or in the beginning with indomethacin. And the idea was that the duct in a normal situation, as you can see on the left side in this panel, is that the pulmonary perfusion is equal to the systemic perfusion. But as we all know, if you got a ductal left to right shunt with a high shunt volume, there will be an increase in your pulmonary perfusion, but at the expense of your systemic perfusion. And then it's more than plausible that the increase in pulmonary perfusion is the cause of respiratory morbidity, like pulmonary hemorrhage, increase in bronchopulmonary dysplasia, the need for an increase in respiratory support, prolonged mechanical ventilation, etc. And on the other side, that it is probably, well, the idea, the hypothesis was that it is causing the renal failure, the necrotizing enterocolitis, cerebral injury, etc. So for that, it was thought we have to treat the duct, we have to close it. So there are three different approaches to treating a duct, trying to close it with medication. The first one is the prophylactic management. We've got the pre-symptomatic management and the symptomatic. Let's go to the prophylactic, and then in a defined weight or gestational range, you give all patients, you gave treatment with cyclooxygenase inhibitors. In the pre-symptomatic management, there's normally a screening program with echocardiography, and then based on the findings in this echocardiography, the determination, is it a relevant or non-relevant PDA, you decide to treat or not. And the last one, and that is what has mostly been done, is the symptomatic treatment. So only when there's a clinical apparent PDA, or there's a clinical condition that is possibly related to a PDA, you will start treatment. And what you can see in the graph, that if you give prophylactic cyclooxygenase inhibitors, you will have a very high risk of redundant adverse effects of the medication, because, well, sometimes the duct closes itself, so you wouldn't need this medication. But it will decrease when you start later and only with symptomatic treatment. However, if you postpone your treatment, it will increase the risk. You will have a risk of prolonged exposure to a transductal left to right shunt and the associated risk. So it's always trying to find the balance. A lot of randomized controlled trials have been performed about the PDA management, and we summarized it in one of our systematic reviews and meta-analysis. And the main message is, there's no effect on mortality. Here you can see the risk ratios and the 95% confidence interval. No influence on bronchopulmonary dysplasia, either with one of these definitions: necrotizing enterocolitis, mortality or BPD, and interventricular hemorrhage. Only thing we find is that if you give the indomethacin or ibuprofen, the duct closes. However, it seems not to be associated with. So we all concluded, well, it's very nice that we try to treat it, but it appears that treatment of a PDA with pharmaceutical drugs is not associated with a significant reduction in severe neonatal morbidity. That has also been shown in this very nice systematic review and meta-analysis recently published by Supik Mitra, almost including 5,000 patients, 68 randomized controlled trials. And the conclusion is that placebo or no treatment did not significantly change the likelihood of mortality, necrotizing enterocolitis, or interventricular hemorrhage. So why treat if it doesn't have the effect that we all want? And we know that the duct might close spontaneously. And if we look at the data, we're mostly interested in the orange-red group, because those are the patients less than 28 weeks. On day 4, about 1/5 will be closed. On day 7, after a week, 1/3. And if you can see from the study from Jana Samburova, you can see, well, eventually the duct will close. However, it will take more time for the patients in the lower gestational age group. So the conclusion was, why treat it if it doesn't have the effect and it will eventually close itself? So a lot of interest and was in the expectant management. In the expectant management, one says, well, it's not the PDA that is causing the adverse effects or the necrotizing enterocolitis, the intravesical hemorrhage, etc. But the PDA is more a marker of immaturity. So the immaturity itself is related to a higher incidence in a patent duct. The immaturity in itself is related to a higher incidence in bronchopulmonary dysplasia, the intravesical hemorrhage, necrotizing enterocolitis, etc. But this doesn't mean there is a direct relation between the PDA and these adverse outcomes. So this is why, if you look at the data, there's an increase in an expected management, so no interventions for a PDA for all infants below 1500 gram. But if you look also in the less than 1000 gram, worldwide, people were reluctant to treat a patent duct. However, to be honest, I think evidence for safety of this approach is is limited and also controversial. Why? Well, let's have a more closer look into all the randomized controlled trials that have been performed and that are included in these systematic reviews and meta-analysis. In this bar graph, you can see all the different RCTs, and this on the y-axis, you see the percentage of patients in the control group that eventually were treated with cyclooxygenase inhibition and or ligation. So, and what you can see, well, the median is 50%, so the half of the patients in the control group were treated. So it's not a proper comparison of treatment versus non-treatment, but what I see, it's a systematic review of early versus later treatment with cyclooxygenase inhibition and or ligation. So that brings up the question, is the statement, it appears that treatment of a PDA is not associated with a significant reduction in severe morbidity, is that still valid? If you don't compare treatment versus later treatment instead of treatment versus no treatment. And this is why we talked about it first in the neonatal hemodynamics working group within the Netherlands, and then together with our Belgian colleagues, and we started the Benedictus trial. And it was performed in 17 NICUs in Europe. So it was in the Netherlands, in Belgium, and one center in Denmark, in Aarhus. It's an international, multi-center, randomized controlled non-inferiority trial in preterm infants, gestational age less than 28 weeks, with a PDA defined as a PDA diameter more than 1.5 millimeters and a left to right transductal shunt. You will have one arm is the expectant management, and really no treatment was allowed with the intention to close the PDA. And the other arm, the treated arm, was the early ibuprofen treatment arm, started within the period of a postnatal age of 24 to 72 hours, according to local protocol, within 3 hours after randomization. So we had a lot of discussion about, because a placebo-controlled trial is seen as the highest level of evidence. We deliberately didn't perform a placebo-controlled trial. It was an open trial. And the reason for this is that I was afraid that if we would do a placebo-controlled trial, we would make the same error in all the RCTs from the past. Because if the course of the patient is not as you would like it to be, then it's always on your mind, well, probably this patient will have placebo, and well, shouldn't we give open label treatment. So we tried a other design, and that is that we randomize the intention of the clinician, which means that if there are two babies on an NICU, same age, same weight, not related, they are randomized in the Benedictus trial. At the first cut, you say, well, this baby has a patent duct because they're enrolled in the study, so they have a patent duct. But it's a marker of immaturity, not causally related. We're not going to treat it. We're not going to check it. No extra echocardiography, etc. And also no other ways of trying conventionally to treat a duct. Then you go to the next incubator, and that baby is randomized into the early treatment arm. You say, well, this duct is probably, there's a causal relationship, might be with the patent duct and the adverse outcome, so we have to treat, and we treat it, and I will show you the flow chart of the study in a minute. We looked at the composite outcome of mortality and or necrotizing enterocolitis, defined as a Bell stage greater than 2A and a moderate or severe BPD. But we also looked at all the short-term relevant neonatal morbidities, and this was all assessed at a post-menstrual age of 36 weeks. As it is a non-inferiority trial, we had to define the non-inferiority range, and that was defined as a significant absolute risk difference for the composite primary outcome with a one-sided 95% confidence interval of less than plus 10% for expected management compared to early pharmacological treatment, which means that if in both arms the incidence of the primary outcome is similar, you'll have 0% of difference. The primary outcome might be up to 10% difference, so higher incidence in the expected management group, and it's still considered, excuse me, it's still considered non-inferiority. So whenever the right-sided confidence interval is within the green or blue area, then it can be considered non-inferior. Note that we have a composite outcome, and of course, a 10% higher incidence of mortality, if it only was due to the mortality, is unacceptable. And that's why the Data Safety Monitoring Board really paid attention to the distribution in between the components of the primary outcome, that was not out of balance. This is the enrollment between December 2016 and December 2020. The median gestational age was 26 weeks. The median birth weight was 845 grams. We got informed consent in 273 patients, and the expectant management group 136 with only one open label treatment. So we were very happy with that it proved that it was successful to randomize the intention of the treating physicians, and because the open label treatment was only 0.7% in comparison to a median of 50% in all the RCTs from the past. If you look at the early pharmacological treatment, so ibuprofen in this study, 136 patients, the duct was closed after one course in 53.8%, which is consistent also with data from literature. If we look at the maternal and neonatal characteristics, there was only one difference in the maternal characteristics, that there was a increased incidence of HELLP syndrome in the expectant management group, 5.1% versus 0.7%. For the rest, there were no difference in the characteristics. Of note, I always think it's very important to compare the population in the study with your own population. The majority of the patients in this study were on non-invasive respiratory support, 3/4. Only 1/4 was on invasive respiratory support. Oh, let's go to the primary, so the composite outcome. What we did see, and that was really striking because we expected a non-inferiority somewhere within the blue range, but we noticed a absolute risk difference of minus 17.2% with the right limit of the 95% interval at minus 7.4%. So we can say it's non-inferior and then non-inferior. Some people might say, well, it's even superior, the expectant management, but given the design of the trial, you cannot conclude that. Although it depends on who you speak about this. Are you speaking to a statistician or a clinical trialist? But it's always different with composite outcomes. So we also looked at the components of the composite outcome. And as you can see, the intention to treat analysis and the per protocol analysis, they showed the same results. But looking at the primary outcome components, so necrotizing enterocolitis, moderate to severe bronchopulmonary dysplasia, and death, you can see that the difference in the primary outcome was predominantly related to an increased incidence of BPD in the ibuprofen treated group with absolute risk difference of minus 17.6%. Looking at all the other secondary outcomes of interest, because we were very interested in interventricular hemorrhages, especially the more severe, so grade 3 and higher, there was no difference in these outcome, also not for renal failure and in the pulmonary hemorrhage group. What was another very striking finding, it was the difference between males and females, especially the male had a higher incidence of the composite outcome in the treated group with an absolute risk difference of minus 30% with the right limit of the 95% confidence interval of minus 17%. Let's go to the limitations and the strength of the Benedictus trial. Unfortunately, we had to stop inclusion of 273 patients, nearly the half of the powered patients, due to very slow recruitment and discontinuation of funding. There was a competing trial to be started in the Netherlands, and we had to stop. However, the results are as they are. Transductal diameter, as we all know, is not the best indicator for hemodynamic significance of the patent duct. So you can argue about that indication. And early treatment was according to local protocols. And they all treated with ibuprofen. Sometimes 2 courses were given, sometimes 3. Sometimes they stopped the first course after effective closure, so after the first dose. So there were some local adjustment, but the majority was treated with 1 or 2 full courses of ibuprofen. The strength is it's the largest RCT, despite we only have 50% of the powered patients regarding the early targeted treatment of a PDA. And I think from this study we can really compare treating versus no treatment in the expected management arm because of there's only 0.7 open label treatment. To conclude, non-inferiority was shown for expectant management in extremely preterm infants with a gestational age below 28 weeks with a PDA compared to early ibuprofen treatment for the composite outcome, mortality or necrotizing enterocolitis or moderate to severe BPD assessed at a postmenstrual age of 36 weeks. And this was mainly due to a significant lower incidence of BPD in the expectant management group. A significant 6 difference was observed from the composite primary outcome, showing an increased risk in male infants after ibuprofen exposure. And to be honest, conducting an RCT in critically ill newborn infants is really challenging. So now to discuss what I think the results suggest harm that is associated with early ibuprofen exposure. And it seems to be that it's largely driven by a higher incidence of moderate to severe bronchopulmonary dysplasia in the early ibuprofen group than in the expectant management group. So the question is, might it be that the cure is more harmful than the condition itself, as shown in this cartoon by Curl and Payton? Well, let's look if there's data about this. And if you go into the literature, there is a relationship between ibuprofen and pulmonary injury. And of course, we always understood that because you give ibuprofen because of a PDA, and the PDA we thought is related to the pulmonary injury, and probably there is a association and probably some causal relation. However, it could also be that it is related to the ibuprofen itself and not to the PDA. That has been shown in observational studies in extremely preterm infants, in a study by Chen et al. And by Jana Termerova from the Czech Republic. But also, if you look in more fundamental research in human umbilical vein endothelial cells, in neonatal rats, the retina, and in zebrafish, there's evidence of inhibition of the angiogenesis by ibuprofen. And very recently, a study was published from China where they measured different angiogenic factors before and after ibuprofen exposure, and they showed a decrease in plasma levels of these angiogenetic factors. So might it be that the ibuprofen has its adverse effect, that it inhibits the pulmonary angiogenesis, and in that way has its effect on the lung injury and the higher incidence of bronchopulmonary dysplasia. If we look at the studies by Ron Kleiman, where they have the baboon model, what they've shown is that treatment improved alveolarization, always a very difficult word. And that is what also been shown. However, they did also see a decrease in vasculogenesis. So probably it might be that it is an adverse effect of the ibuprofen or cyclooxygenase inhibition, because it's always intriguing. That's why I started. We found out that the prostaglandins are important for ductal patency, so you should inhibit it if you want to close the duct. So we only focus on that pathway. And right now we're either using cyclooxygenase inhibition, but you can also use peroxidase inhibition. So that's paracetamol. But it has the same effect. It's influencing the same pathway. And we didn't pay any attention to all other processes in the body that might be influenced by this inhibition of the prostaglandins, such as, for example, the angiogenesis. So I think there are different clinical phenotypes. If you've got a hemodynamic significant PDA, and we can spend many hours about the definition of an hemodynamic significant PDA, but let's call it a transductal left to right shunt with a high shunt volume. And then you can give either cyclooxygenase inhibition, ibuprofen, indomethacin, or you give peroxidase inhibition, paracetamol. And there are three different responses. If you got a successful closure with your treatment, or you can have a failed closure with your treatment. The third option is that you have a partial closure or a temporary closure. It will close, but later on it will open again. I think if there's a successful closure with your treatment, that the treatment might be beneficial because you've got a reduced exposure to hemodynamic significant PDA that outweighs the potential adverse effects of the treatment. If you got a failed closure, I think that's the biggest problem, because you've got first a prolonged exposure to the hemodynamic significant PDA, but added to that also the potential adverse effects of the treatment you've been given. But this is the real difference between those two. And in between, it's very difficult to say whether it's beneficial or injurious. It depends, of course, between the balance of duration of exposure to the PDA and the potential adverse effects. So what can we learn from the PDA trials? I think all the randomized controlled trials on PDA management are characterized by a heterogeneous study population, a large variation in the definition of a hemodynamic significant PDA, a lack of comprehensive echocardiographic assessment, inefficacy of the intervention to successfully close the duct, and a high incidence of open label treatment in the control group. I think from the Benedictus trial, we can conclude that it looks like expectant management is safe in the majority of extremely preterm infants. And data suggests that early exposure to ibuprofen is associated with an increased incidence of lung injury, might be the effect on the pulmonary angiogenesis. So what would be the preferable principles for a future PDA trial? Because I don't think we've got the answer yet, but we're getting very important information. I think we should select a study population with a high transductal shunt volume. Use, for example, echocardiographic PDA severity score. And then we have to use a preferably safe and effective treatment that results in a successful ductal closure versus a real expectant management. And we should aim at no open label treatment in the expectant management group. So it's essential to have clinical equipoise within the physicians. So it's speculating and maybe a bit provocative, but I would really do a similar study as the Benedictus trial. The same study population, gestational age less than 28 weeks, but then with only the ones with a high transductal shunt volume based on echocardiography, one or a new PDA severity score, and look at the first expectant management group, same as within the Benedictus, and look at the post-menstrual age of 36 weeks at the incidence of bronchopulmonary dysplasia and/or mortality. Then, if we want to have an effective treatment, that would be transcatheter closure. And maybe it should be interesting to look at that at less than 72 hours. However, I also mentioned preferably safe. Our North American colleagues will say, I can do it in every baby with 100% effectiveness and no risk of injury. I'm not sure we're there yet, but this would be probably a very interesting study. That brings me to the, I want to thank many people have been involved in this Benedictus trial, especially also the patients and the parents of the patient organization, and everyone that was involved. And I want to thank you for your attention, and I'm happy to answer any questions.
Thanks, Willem. That was a fantastic overview of your trial, all the issues which were raised and all the issues we run against, and how you try to very elegantly solve that in your particular trial design, and still ran into certain sort of issues which are quite clear. And I really like your explanation of your findings, talking about the pathophysiology of the potential side effects of the medications we're given. And so we have quite a bit of time to discuss, and I'm burning with some questions as well. Remti Hanger started with a question. Hey, of these effective treatments which we have now, we have, of course, indomethacin, ibuprofen, paracetamol. Which is actually the most effective in this time frame?
Well, if you look at the data from Suvik Mitra, the meta-analysis, I think oral ibuprofen seems to be the most effective in ductal closure. So in that sense, however, given the results of the Benedictus trial, I'm very reluctant in starting treatment in patients, especially in early treatment. So in the first week.
With any
With any, and we just in the Netherlands, after publication of the results of the Benedictus trial, we made the new national recommendation. And what is in the PDA management, especially over 28 weeks gestational age, we don't look, we don't treat. Below 28 weeks, first week, we don't look, we don't treat. Only when there's after the first week of life, there is some worries about potential PDA if the course isn't satisfying. We advise to do an echocardiography, and based on hemodynamic significance, and that is defined as a pulsatile transductal blood flow pattern and a negative diastolic flow in the descending aorta. And that what we use to define hemodynamic significance, we might consider to treat. However, if you've got a male patient, are you going to give ibuprofen because you start to treat later? We know that the effect of the treatment probably is less. Or should we move over to transcatheter closure? And that's the dilemma we've got right now. So we don't still have the answers and a lot of more questions, because I don't believe we don't have to treat any patients. From a pathophysiologic perspective, it can't be good to have a high pulmonary perfusion and a decrease in your systemic perfusion. I don't believe that. So we have to pick out those patients with a high transductal shunt volume. And that's what we look into the data right now in the Benedictus trial, because we got all the echocardiographic data. And one of our pediatric cardiologists is doing her PhD on evaluating all these echocardiography, trying to find out if we look at different ways of defining a hemodynamic significance. What's the effect between the groups? Treatment versus non-treatment. What do we see then? I think that is important. We have to look. So I'm convinced that the treatment we're giving right now is worse than the original condition, but that doesn't mean you shouldn't treat. However, we don't have the right treatment. I think we have to look for the right treatment.
Yeah, I think the term is you want to close the PDA to reduce the pathophysiological effects of the PDA, which is the increased preload, but also the reduced afterload with reduced perfusion pressure to your kidneys. And I agree with that. And how we can do that is a challenge. And I'm really glad to hear, because I was about to ask that as well, you know, in all these big trials which are happening now, we need to have information of subgroups more than just PDA size. We need to know about systolic function, diastolic function, estimates of pressure. We need to use some of our modern sort of tools to assess these PDAs and see if we can actually select babies better, not only on PDA, but maybe also on gender, which is really interesting as well. You know, a follow-up question, and that's also what I see in practice. And, you know, the IOI group would recommend it, even though they give, you know, on average 28 doses of paracetamol to the very young babies. Is that, you know, when we have one medication doesn't work, we give another medication. And some also trials are using combined medication. What's your view on that?
I think I don't combine because I think the effect will be the adverse effect will be added. It doesn't seem logic to me to give both indomethacin and ibuprofen, because there are studies that have looked into that. The transition to paracetamol, I understand, because it's considered to be less harmful. I'm not convinced. I personally don't use paracetamol, so I'm biased. I don't use paracetamol for ductal closure. I'm also worried about how easy paracetamol is given on our ward, because the patient is discomfortable. I don't know. Well, let's give paracetamol. If you really look into these data, and inhibiting the prostaglandin synthesis, and it might have an effect on the lungs, on the vasculogenesis. I think, and there are also data in studies showing that paracetamol has the same effect and is directly related to lung injury. Also, given, I'm not sure it's safe, given the potential adverse effects on longer term behavioral problems, etc. It's not good science yet, but we looked in the expected management group, quick and dirty, the use of paracetamol. And paracetamol wasn't allowed to give for treating the duct, which is a higher dose than, of course, if a patient needs analgesia, we are allowed to give paracetamol, but it wasn't allowed to give it in a higher dose, so it might also close the duct. And in the expectant management group, the use of paracetamol was lower than in the ibuprofen treated group. Quick and dirty, we looked at the use of paracetamol, and we saw in the expectant management group that patients that had paracetamol, they had a higher incidence in the moderate to severe BPD. However, we have to look into confounding factors. Were they more often operated, had surgery, etc. So we're going to, but there are signs that tell me I'm not sure it's safe. So the Benedictus showed us that it's not a bad thing to not treat for the data we've got right now. So why use a potentially injurious medication in that population? So I don't do it myself in our clinic. We don't. Yeah.
No, but you will see in our region, it is definitely increasing in use and size. And I would agree with you here in one of these vasculogenesis kind of events. If you look back at the data, there was also an increased risk of ROP in treated infants versus not, which is purely vasculogenesis as well. So we're on to something. We're on to something. We know something, what something is there. And look, another question which is of course already been placed many times is about, you choose 24 to 48 hours or 24 to 72 hours. What is the ideal time to treat a PDA?
It depends. If you look from a pathophysiologic perspective, if you think the high transductal shunt volume with your increase in pulmonary blood flow at the expense of the decrease in the systemic perfusion, you should treat it as early as possible to limit the time, the duration of the exposure to a high transductal shunt volume. As I've learned from the Australian colleagues, Nick Evans and Martin Klukow, well, they showed us all that we thought it only starts the increase, the hemodynamic significance of a duct not in the second half of the first week of life. Already within the first day, you can see a high pulmonary perfusion. So that's why I also understand, and in the DTEC trial, it was already started the treatment on day one. We thought because it's always difficult on day one to have the informed consent, etc. We said, well, within 24 to 70 hours, we have the early treatment. So from a pathophysiologic perspective, I think the more you can decrease the exposure to a patent duct, the better. However, how to do that? That's difficult. With the medication we got right now, don't do it within the first week. The problem is, as I already told, if you give it in the second week or the third week, you have to increase the dose. That's what we know if we want to have an effective closure, although the chance of closure is getting reduced. So that's the big dilemma. Probably transductal closure might be the solution. And I really think it would be very interesting. And I think I can ethically, morally, I can defend that if it's safe enough to do a transcatheter closure within the first week of life, to have a study like the Benedictus, but instead of ibuprofen treated, a transductal closure treatment versus expectant management, that could give us really an answer. Is it the elimination of the transductal shunt that is essential? Will that improve outcome or not?
Yeah, and that's look, they're getting there. They're doing a trial now, which starts from week 2 in America, and we're waiting eagerly on those kind of results. And before they have that, there's still concerns about the safety data, as you mentioned. And I guess I find treatment much easier after sort of 5 days of life, because you can measure cardiac dysfunction in a way, in lots of little details, and with the respiratory signs. So selection of patients from sort of a week of age is, I find, relatively easy if you add diastolic dysfunction into it and left atrium strain. But in the first 3 days, it is difficult. Even using all the fancy measurements I have at my exposure, it still remains a challenge, I guess. I have a question about, okay, the supportive care. There's different names and different terms and different sort of treatments are mentioned. The 3 are PEEP, volume, and diuretics. Which one do you use, and how did you use them?
Well, let's be very clear. In the Benedictus trial, it was not allowed to give fluid reduction, fluid restriction. That's also very strange to me to give that as a treatment for a PDA, because if the consequence is a systemic hypoperfusion and you restrict fluid, you will decrease cardiac output. And that has been shown in a very elegant Belgian study, that if you give fluid restriction in a patient with a hemodynamic significant PDA, that you will decrease SVC flow. So I can understand it from the pulmonary perspective. However, from the systemic perspective, it's not logic to give fluid restriction. So also the diuretics, I'm not convinced by that. So in the Benedictus trial, it was not allowed to aim at the duct and then give fluid restriction and or diuretics. For other reasons, for other indications, of course, you can give fluid reduction but there was no difference between the groups regarding diuretics and the fluid intake. PEEP, CPAP, meninary pressure is interesting, because if you want to conventionally try to influence the transductal shunt, it's either trying to decrease the radius. That's what you try to do with medication, but we just discussed all the adverse consequences of that. You can try increase the viscosity, and some people say you can aim at a higher hematocrit, but also you can try to increase the pulmonary pressure, and with that decrease the pressure gradient. So what is said is that that way you can try to increase meninary pressure, or PEEP. Of course, that will theoretically decrease your transductal shunt. However, you must be aware of the potential effect on your lungs with volume trauma, and it's always the balance, trying to find the best balance in that. I hope that's an answer to your question.
Yeah, is it vague as in the literature?
Yeah,
it's difficult to choose, and there is different ways to looking at it. I guess if there is true, diastolic heart failure, I think diuretics still have a place, but it hasn't been properly studied, and as thing we still have to do. And that's probably where Sam's question, he's from Singapore, is sort of about. We talk about the short-term NICU outcomes, and we know a percentage stays open sort of afterwards as well. And if you talk to an adult cardiologist, and he talks to a patient with a VSD, even pediatric cardiologist, to go like, yeah, no matter what, if there's no signs and symptoms, this could be a years-long problem. So it's a problem. So we need to manage it. Do you know what a long-term effect is of a persistent PDA NICU which stays after the NICU?
This is a very important topic, and we have to really pay attention to that. Right now, if you've got a patent duct, we don't know if you're over 28 weeks, because we don't look. We never check, and we just leave it as this. If you talk to pediatric cardiologists, they think we're crazy if you're less than 28 weeks. There's a patent duct, and we just send them home. And So I think there must be a follow-up of these patients. We are looking into all the data from the Benedictus trial group in the expectant management group, and we're trying to get funding to do another echocardiography at the age of 5 to 8 years to see and to look into that, and also in collaboration with our colleagues in Groningen, the experts in pulmonary hypertension, together with our center, and we're looking at that. If you look at the observational studies, they show that because everyone is afraid of the flow-induced pulmonary hypertension, the Eisenmenger phenomenon on the longer term, the chance is really low. And if you look, in January, over 85% of the patent duct which were open at discharge to home, they still close spontaneously. And there's only a minority of the patients that need intervention, for example, transcatheter closure. But I don't think it's wise just to send the patient home and don't look at it anymore. It does need a follow-up. And we agreed with the pediatric cardiologist that they're going to the cardiologist outdoor clinic to be followed for the first years and to see what the effect is. And it's their profession, their expertise to determine if we want to close it or not. From the 2 years follow-up we've got right now, we don't have the exact details on the cardiologic side, and we're also looking into that. The neurology, the preliminary data, no difference between those two groups.
Now that's important to know, and also an important message that, you know, what we don't know, you can't just leave it and go, it's going to be okay. We got to have a look at that if we change our management, because we've been doing treatment of PDAs for 60 years. If we change that, we also need to look at the long-term effects of such sort of change, a significant change in medical management. Look,
just to stress, because a lot of people, they always say to me, oh, well, is it really safe that you say you shouldn't treat any duct? No, that's not what I say. That's not what the result of the Benedictus trial is. However, the way we treat right now is probably more injurious than non-treatment. However, I'm still convinced there is a small portion of patients, selected patients, that should be treated. Although I don't know yet how, transcatheter closure, but we also should pay attention to later consequences. Yeah.
No, I totally want to echo that same feeling. I think what we're doing now, sort of that you know, treat them, sort of most of them has to go to treat a very selective group. And like I said, it becomes relatively easy after, you know, seeing diastolic heart failure or seeing significant pulmonary effects or renal effects. You go like, that's easy. But in the first couple of days, selection might be still a challenge to everybody who's studying the PDA. Hey, Willem, I got a question. We did, and it should be the last question before we sort of close off, I think, but unless some more questions will flow in. We did a smaller trial, and Nick, Martin Kluk and ourselves, we did 2 trials, similar than yours, and very only 2 patients open, or 4 patients open label treatment, was only 72. And we did it as a pilot trial, and because one of the issues we had, and you described it in your trial as well, is recruiting patients into the trial. And we found that it was really difficult to explain to parents what we were actually doing. Oh, we've been treating all the time, but it wasn't really working. We found out that it never had any benefits, and now we want to not treat. How did you deal with that?
This is really the challenge. You have to talk to parents who are in a crisis. They've got their child on the neonatal intensive care. They didn't expect that. And then you have to explain a very complex study. So it really asks a lot of your skills to explain that to parents in their most vulnerable period, the anxious period. And so what we did is to have good information written, but also a video, so they could have their time to learn more from that, and just to have a very open, transparent discussion with the parents. We really don't know what to do. I can be sure that whatever in which arm the patient will be randomized, there's what we know, no difference. There's no risk, because otherwise we wouldn't do the trial. And if otherwise you would have been randomized by postal code, because within the centers in the Netherlands, it's only a small country, but it's very nice. In the morning, I go to center A, they say, well, I know the data, I should study it all, we should treat them all. And 1 hour later, I'm at another center, and they say, I've studied all the literature, and we're really sure we shouldn't. We should treat. And so it's the opposite. So you would be randomized by postal code, because if you go to Amsterdam, it would be different than if you go to Utrecht. And so that is how you try to explain to parents, not only very technically trying to talk about the pathophysiology, but to put in the perspective for the parents. But it's really challenging, really challenging in these early times on the neonatal intensive care for parents that are scared.
Yeah, not applies only to the PDA trials, but any kind of trial.
No,
look, Willem, it was a real pleasure to listen to you and your opinion and the data, your wonderful study. Really, it brought a lot to us to think about. But I think your subtitle was correct. More questions than answers, or still questions. And we're going to hopefully work on it. Hopefully your sub-study is going to reveal just a little bit of where we can look at and which parameters can actually help us select. All the audience, thank you so much for joining. I will put up a slide with a QR code if you want some CDP points. And Willem, thank you so much for joining us, and bye to all. Okay.
Thank you for having me, and it was a pleasure. All the best. Enjoy your day.
All right. Bye, Willem.
Bye.